It's my pleasure to welcome you everybody to the third collaborative roundtable webinar and the last one for this year on behalf of the Cube Plus Steering Committee. Today, our topic is the importance of lifestyle management in cardiovascular disease prevention. Cube Plus is cardiologists unified in building excellence in diabetes. And this activity is part of four main activities for this year. The other ones are the CCC 2020 plenary symposia available on demand, 3 accredited symposia, educational modules for cardiologists that will be launching on September 2nd, so very soon, and key diabetes updates from upcoming international meetings soon to be starting as well. Today, our objectives will be to describe the role of non-pharmacological interventions, including nutrition therapy, physical activity, and weight management in cardiovascular disease protection of people with diabetes. The second one is to apply the latest evidence and expert recommendations on these non-pharmacological interventions to clinical practice. And then collaborate with other members of the multidisciplinary care team to promote lifestyle changes and prevent CV events in people with diabetes. And I have the pleasure also of introducing 3 wonderful speakers that have specific expertise to address our objectives. Hopefully, Dr. Stephen Piper will be joining us soon. Already here with us, we have Dr. Philippe Lavoie-Lallier, and we also have Dr. Sue Peterson. As you can see, the plan was to speak about the role of nutrition, the role of physical activity in the CV protection of people with diabetes, and the pragmatic approach to weight management with Dr. Peterson, and then a Q&A session. And Dr. Lallier has agreed to start with this presentation. Dr. Lallier is a colleague and a friend. He's a cardiologist and associate director of CV prevention and rehabilitation at the Montreal Heart Institute and our rehab center, EPIC. He's also a clinical professor at the University of Montreal in the Faculty of Medicine. And Philippe, please go ahead. Thank you so much for being here with us.
So it's a privilege. Thank you very much for the invitation. It's a privilege for me to represent the EPIC Center, the Montreal Heart Institute, in this very important webinar. It'll be my privilege to, again, discuss physical activity. These are my disclosures, but none of them really pertain to this presentation. So we'll skip those and go to the next slide. So by way of introduction, I would like to submit to you a brief reflection on the fundamental goal of management of diabetes. Is it really optimizing glycemic control through optimal medical therapy? On the right portion of the slides, you can see that the major trials, whether they are historical trials or very recent trials, the red triangle show the residual risk. And despite the very best medications we can give to these patients, unfortunately, residual risk is really, really important. And something needs to be done maybe differently to possibly change the nature of the disease as opposed to treating the consequences. So the true target of therapy, in my mind and in our mind, in our philosophy, maybe should be the reduction in morbidity and mortality associated with diabetes mellitus, but including quality of life, and maybe primarily through diet and exercise, plus or minus medications rather than the reverse. It's always small characters and the guidelines suggesting that we should go through this in the first place, but lots of focus maybe should be on physical activity and diet. So, of course, when we look at the literature in the last 20 to 30 years, ample data and suggest that there's major benefits of physical activity in patients with diabetes mellitus. Whether we look at key biomarkers, A1C, glucose, insulin resistance, cholesterol, blood pressure, abdominal and visceral fat, whether we look at cardiorespiratory fitness, muscle mass, chronic kidney disease, retinopathy, overall quality of life, including neurocognition, which is a new field, which I will be briefly allude to a little bit later, and of course, cardiovascular and overall mortality. There's absolutely no question, and the benefits cannot be overstated, of physical activity in this context. So what do we mean by physical activity and exercise? Well, there are supervised and unsupervised sessions. And if you look at the literatures and the different protocols, they will typically specify whether they were supervised or unsupervised. And of course, if you look at the physical activity itself and the exercises, it can be either aerobic, continuous or interval training, resistance, and flexibility. So what exactly is the best strategy for patients with diabetes mellitus? Well, a very important systematic review and network meta-analysis published by Dr. Pan and colleague in 2018 suggested that combined exercises showed more pronounced improvements in A1C than either supervised aerobic exercise or supervised resistance training alone. So therefore, based on this strategy, a combination is typically prescribed for patients with diabetes. Now, for how much, for how long, what exercise type should be done? Fortunately, most of the different associations, scientific associations worldwide agree on what should be done. And therefore, this is very useful to clinicians that try to prescribe exercise. And of course, when we look at frequency, the consensus is that exercise should be done on most days and at least on 3 days per week. And no more than 2 consecutive days should go without exercise, and the intensity should be at least moderate to high for maximum benefits. If we ask the question of how long should people exercise for, well, it's a per week measurement of 150 minutes. Multiple combinations are good, whether they are 3 times 30 minutes a week, 5 times 30 minutes a week is fine. Whether they are 3 times 50 minutes is also good. And this should be also, in addition to aerobic training, 2-3 sessions of resistance training, as mentioned previously. This is quite important. And of course, if we look at the data in the literature, supervised appears to be particularly effective, although the unsupervised and home-based programs are also helpful. Now, what about intensity? Of course, it does matter. There is a very important linear relationship between the amount of activity, which includes intensity, of course, but it should be absolutely clear that any kind of activity is much better than being sedentary. And of course, even standing up every 30 minutes makes a difference. So it should be clear that this is not necessarily crucial to be a marathon runner. So what about self-efficacy and motivational tools? Well, they are very helpful because adherence in the long term is crucial. And if you use pedometers, accelerometers, or fancy intelligent watches, all of them are good and should be used when you interact with your patients to motivate them and to ask them for their stats regarding their training. Now, how do we prescribe exercise practically? We strongly suggest to use the progressive FITT program. This is the American College of Sports Medicine suggestion. It stands for frequency, intensity, time, and type. We go across the different activity types, which are aerobic, resistance, and flexibility. If we look at aerobic training, of course, we said most days. Intensity should be about 60 to 70% of what is perceived by the patient to be maximum, that is Borg 12 to 14. Amount of time, we already said 150 minutes per week on at least 3 days per week. And the type is up to them, whether they like continuous, HIIT, or a mixture of both is also good. And of course, what exactly we mean by this type of intensity is it amounts to about brisk walking. And of course, it can be the activity types can be either technical or non-technical. They can be walking, bicycling, swimming, racket sports. They are all good. What about resistance? Again, 2-3 times per week, non-consecutive days to allow for recuperation. We typically prescribe 50 to 85% of maximum repetition, 1 repetition, so maximum weight they can lift. You go for 70% and you go for 1 to 3 sets of 10 to 15 reps. And you typically request that most muscle groups be targeted. So therefore 8 to 10 different exercises are typical. And of course, whether you need machines or free weights is not entirely clear. Most studies have shown that machines and free weights are particularly efficacious, and the maximum and best results are with those machines. However, if you don't have those, you travel, whatever, resistance bands and body weight are perfectly good to also help. And what about flexibility and balance? This is probably particularly important in older patients and patients with peripheral neuropathy. We suggest 2-3 days per week. Stretching and balance, whether they are static or dynamic, is perfectly fine, but it can be perfectly included in the prescription and very useful, again, in particularly in older patients. What about the specific considerations for people with diabetes in regards to physical activities? Of course, we are sometimes a little bit reluctant in those patients who are sometimes a little bit obese and are very sedentary. We would like, of course, first and foremost, to minimize the exercise-related cardiovascular events related to physical activity. Medical clearance, fortunately, and exercise stress testing is generally not necessary or indicated in most low-risk or asymptomatic individuals, I should say low-risk and asymptomatic individuals, for low to moderate intensity training programs. So that's most programs. Resting ECG plus or minus exercise testing is generally indicated for broadly symptomatic individuals, because we know that patients with diabetes sometimes have blunted cardiovascular symptoms. And those with risk factors, including peripheral vascular disease or a history of symptomatic atrial thrombosis, these patients should probably be medically clear and have an exercise stress test in order to help in the prescription of the activity and then in the initial intensity. Of course, most people with diabetes have impaired thermoregulation, so therefore particular attention should be on the temperature. Whether it is extreme heat or extreme cold, we need to be cognizant of this fact and therefore adapt the training sessions. Again, hypoglycemia might be also an issue. And of course, it can happen during or after exercise. So therefore, if patients use insulin secretagogues or even insulin injections, dose reduction is typical, and the patient need to understand that they will eventually know the details about how they react to its physical activity, and progressively they will reduce the dose or even consume an increased carbohydrate intake during or after exercise. Particularly interesting, some of the protocols have suggested that if you use HIIT and you use resistance exercises early in the routines, this can be helpful in order to mitigate the risks of hypoglycemia. So it is typically what we do. Regarding diabetic retinopathy, this is, of course, the case of uncontrolled disease. Of course, this is a particular risk, and clinicians should be cognizant of their patient and know whether they have this condition, because it would be contraindications to any kind of vigorous activity, especially isometric training or very high intensity aerobic training. And finally, with regards to foot injury, we all know that diabetic patients have sometimes impaired sensations in the periphery. So therefore, daily inspection and attention to shoes is particularly important in patients who start the programs and who start to exercise on a regular basis, and they should include this inspections as part of their routines. Now, I would like to share with you now the first experience that we have with the clinic that we've put forward under the leadership of Martin Junot in 2019. So our group, Montreal Heart Institute Prevention Center, called EPIC, started a comprehensive lifestyle clinic for patients with T2D. Dr. Josette Iglesias-Grau, our excellent fellow, will present the results at CCC 2021, so stay tuned. The interventions that were included in this clinic included detailed nursing and dietary counseling. With regards to dietary counseling, we promoted the moderate carbohydrate restricted Mediterranean diet, and we included time-restricted feeding if we needed to. And of course, we included a personalized exercise prescription that targeted at least 30 minutes of moderate aerobic training 5 times a week, plus strength training, and the duration of the program was 12 months. 96 patients completed the intervention in 2020. So this is, of course, partly during the pandemic. And of course, this represents 91% despite the sanitary situation, 91% of the cohort. The mean age was about 68 years, and 37% of patients had the cardiac heart disease. 23% of patients did not have a glucose lowering therapy at the baseline, and the mean initial A1C was 7.3%. So at program end, all anthropometric and insulin resistance measures were significantly improved with a p-value of less than 0.01 for all of them. As examples, the A1C was reduced by 0.8%. HOMA-IR was reduced by a factor of 2.3. Circulating insulin was reduced by 24 millimole per liter. Weight was reduced by 4.5 kilograms, and waist circumference was reduced by more than 5.3 centimeters. When we looked at the criteria of an A1C less than 6.5 for partial remission, this was achieved in almost 60% of patients. So this is very important for us to evaluate the result, and we are looking forward to improving on the criteria and improving our interventions in order to further help the patients. Now, I would like to end the presentation by discussing a little bit new areas of research. We are extremely fortunate to have Dr. Louis Bérard working in our center. He's an internationally recognized researcher in the field of neurocognition. It is one of maybe the next pandemia for patients with diabetes. We very well know that patients with diabetes and cardiovascular risk factor in general, but diabetes in particular, have an increased risk of neurocognitive dysfunctions. Fortunately enough, the patients in our center do not look like this one for the most part, but some of them participated in the trial using functional NIRS and dual task walking. And our findings provided evidence that participation in regular physical activity may be especially beneficial in individuals with cardiovascular risk factors by promoting brain and cognitive health, thus potentially contributing to prevention of cognitive decline. So hopefully this is something we will see more details, and we will learn more in the future. But for our patients with diabetes, this might be very important in the future. Now, another area of particular interest is the access to care. We have very good specialists, we have very good clinicians, we have very good professionals that work and can offer advice. One of the key issues is having access to those professionals. The pandemic has been a major problem in many different ways, but it has sparked the COVIPIC trial in our center by our group. And this COVIPIC trial was meant to evaluate the remote monitoring of home-based physical activity alone versus home-based physical activity with physical training and cognitive training, in order to see whether we can achieve the same types of benefits as we do for in-person training and supervised physical training. This will be maybe the future, and it holds a lot of promise for access to care. Now, I would like to end with a very provocative study coming out of Hong Kong in 2020. This group suggested that partially the response to exercise in diabetic patients might be explained by differential changes in the microbiome in the gut. And of course, depending on how patients responded to exercise, different bacteria expressed and different bacteria increase in numbers, and depending on the differential response and baseline features, you could predict and you can expect different responses. So maybe if we further understand this link between exercise and beneficial responses in diabetic patients, will be helpful in the future. So the key messages by way of conclusion, the key messages I would like to share with you on exercise and physical activity for patients in diabetes mellitus. I think it should be clearly the cornerstone of modern and global approach to treating diabetes. And of course, this global approach should definitely include prevention and remission, and not only treatment of glycemia with medications. Of course, there are proven clinical benefits that cannot be overstated. They are multiple, and they absolutely should not be strictly limited to measuring weight loss. Weight loss is a very small part of it. Of course, prescribing exercise is, of course, very important and should include resistance and aerobic exercises. And I strongly believe that it is as important as any medication, and it should be stated by cardiovascular specialists that this is part of the treatment, not something that can be done or not done and overlooked. And of course, I strongly suggest we use the progressive FITT because it is easy, fairly simple, and numbers are fairly easy to remember, and they can be fairly, it requires limited adaptation for personalized medicine. With regards to individuals with diabetes mellitus or pre-diabetes, they should be encouraged to exercise regularly in order to change the nature of the disease and potentially decrease the amount of patients that will develop full-blown diabetes in the future. And there's a window of opportunity that cannot be overlooked. And finally, the adherence to daily exercise routine is absolutely crucial in the long term. And we need to develop support measures, and they are clearly useful. We should be looking out for those and also in the near future. So I would like to stop there and ask Dr. Peterson to go forward.
Thank you so much, Philippe. I'm sure there will be lots of questions. I hope I see someone with their hand raised here, but I would encourage everybody to think of their questions and write it in the Q&A sector at the bottom of your screen. You can access that. And it is my pleasure to introduce Dr. Sue Peterson. This might give us more time for questions, actually, so no problem, we can handle it. Dr. Peterson is our specialist in endocrinology and metabolism and a diplomat at the American Board of Obesity Medicine. She's involved in diabetes and obesity clinical research, has a busy practice as well in the C-Endo Diabetes and Endocrinology Clinic in Calgary. She's become a leading voice in how to treat diabetes and obesity and educates healthcare professionals globally. She also has her own website, as you'll see, about weight management and diabetes. And welcome, Sue. You can take over.
Wonderful. Thank you, Eileen. And thank you very much to everyone for joining us tonight. It's wonderful to hear and see the interest in learning more about lifestyle interventions to support people with diabetes in the context of cardiovascular disease. So we know that 90% of people with type 2 diabetes have overweight or obesity. So it's really important for us as healthcare providers to have a good understanding of obesity and how to counsel our patients, how to support them in managing their weight, because we know that that's a really powerful risk factor for diabetes, for worsening diabetes control, cardiovascular disease, and so forth. So what I've done today, we'll just, I think I've lost control of the screen here, you guys. Oh, there we go. So these are my disclosures. So in the next 10 to 12 minutes, I would like to talk through the pragmatic management of obesity with a clinical case, because what we really want is something tangible. How am I going to change my practice when Randeep comes into my office tomorrow? So let's meet Randeep. He's 52. And he's had type 2 diabetes for a little over a decade, and he had an MI 3 years ago. And he comes into his cardiology clinic because he's having his routine assessment and he needs his medications renewed. And through the appointment, he mentions, you know, I'm trying to lose weight. I know I've got a weight issue. I struggle because I've got cravings. If I lose some weight, I get hungry and I get hypoglycemic. If I try to exercise more, I cut back on food, I get low blood sugar. Everyone keeps telling me I should eat less and move more. But when I do, I get low sugar, I get hungry, and I can't keep the weight off. So we look at some of his details. He's got good diabetes control. He has obesity, BMI is 35, BP's under good control, good renal function, LDL's at target. And here we see the medications he's taking, including metformin, a DPP-4, an SGLT2 inhibitor. He's on gliclazide also for diabetes control, and the usual cocktail of cardiac medications. So when we're trying to help Randeep and trying to understand where he's coming from, it's important for us to understand the science of obesity. And this is a challenge because in medical school, in nursing school, in dietary education, there's very little learning about actually the pathophysiology of obesity. So let's take a minute and just go through just very high level. Again, we've only got 10 minutes, but at a high level, what are some of the contributors to the pathophysiology of obesity? So we see across the bottom of the screen here that there are many pathophysiologic contributors, and we can look at genetics, over 200 genes now associated with obesity, hormones that come from the gut, the pancreas, the adipose tissue, which influence the feeling of hunger and fullness in the brain. So if you've got a different profile of hormones, if you've got more of the hunger hormone ghrelin or less of a fullness hormone response when you eat, then you have a tendency to carry a higher body weight. There's many medications that can contribute to weight gain. We then introduce the hedonic input, and this is the experience of food. This is the wanting and the liking of food, and has to do with the release of dopamine and opioids in our brain. Well, different people have different dopamine and opioid responses to different kinds of food. Some people get that release from activity and some people don't. So this can have an influence on carrying higher body weight as well. Now, if we take many of these pathophysiologic inputs, the gut microbiome, that's another one that Philippe mentioned, but we can't talk about that anymore in the interest of time. But if we take all of these things and put this in our obesogenic environment, which has only gotten worse with the COVID pandemic, we see that it's very clear that the majority of Canadian adults have overweight or obesity, and it does not come as a surprise when we try to understand the science behind it. Now, many patients like Randeep are able to lose weight with dietary intervention. So there's lots and lots of studies that have shown that. Some people do not have success, many do, but where the vast majority, where almost uniformly we have consistency, is that well over 90% of people who lose weight are not able to keep it off. So even if you can lose weight to begin with, it's tough to keep it off. And the reason for this, again, comes back to the science. So after weight loss, the hunger hormone ghrelin goes up, the fullness hormones, of which there are many, go down, and these changes persist long-term. So they drive our brain to tell us that we're very hungry, that we don't feel full, we need to eat more. And in addition, our energy expenditure goes down, our metabolism slows down a little bit. Why? Because we are engineered to survive famine. Our bodies want to regain the weight. So when Randeep loses weight, he's getting hungry, he's having trouble to resist, the cravings are higher, the dopamine and opioid response are higher, everything is primed towards weight regain. So when we hear that Randeep gets hungry when he loses weight and has cravings, we understand now that this has to do with the science of obesity. The other thing that we are seeing, and I think I'll come up with this a little bit later, but the hunger when he loses weight may also be related to hypoglycemia because he's on a medication that can cause hypos, and we'll come back to that in a minute. So in the Obesity Canada Clinical Practice Guidelines, which we published a year ago, we're very proud of them. They're 700 pages long, 19 chapters, and it was 13 years since the last guidelines were published. So a lot has changed. We recommend the 5 A's of obesity as the pragmatic clinical approach to addressing obesity in clinical practice. The first A of obesity is to ask permission to talk about weight. So we want to not make our patient feel shamed. We don't want them to feel embarrassed. We want to show them that we're empathetic. Now, Randeep comes in talking about weight, so we don't need to ask permission. But if a patient doesn't come in talking about weight, we want to ask, hey, is it okay if we talk about your weight today? We want to then assess for comorbidities and contributors to that patient's weight struggle. And perhaps another day we can go into that in more detail, but there are certainly many things: mental health, mechanical issues, and knee pain, financial security issues, many things that can contribute to the weight struggle. Now, Randeep has told us he gets hypoglycemic when he tries eating less or being more active. And here we have a medication, sulfonylurea, that is clearly contributing to the weight struggle. We know that it causes weight gain. It's preventing him from having success when he tries to live a healthier life. So we want to try to get rid of the glycoside in his diabetes care regimen. Now, the third A of obesity is the advise, and this is the strategy for treatment approach. Now, we see here that we've got 3 pillars, and that's psychological support, pharmacotherapy, and bariatric surgery. And these support the roof, which is medical nutrition therapy, we'll talk about that, and physical activity. So the point here is that diet and exercise are actually not the treatments. Rather, the 3 pillars of obesity treatment support the outcome, which is an easier ability to adhere to a healthier lifestyle. So we certainly still counsel on healthier eating patterns. We certainly counsel on physical activity, all the wonderful benefits that you've heard from Philippe, but we want to be thinking of those at the outcome is a better ability to adhere to those recommendations with addressing the pillars of obesity treatment. Now, because we're talking about lifestyle today, we won't talk about pharmacotherapy or bariatric surgery, but I just wanted to touch briefly on a couple of psychological therapy principles. So it doesn't help for me to say, okay, go and support your patient psychologically. Okay, well, what does that mean exactly? So there's a wonderful chapter in the obesity guidelines. This is a screenshot from my website where I blogged about each chapter in the guidelines, actually. So you can go in and type in psychological. This will come up. So there's your notes from tonight. It's recommended to have a multi-component psychological intervention, including behavioral modification, cognitive therapy, and values-based strategies. And now, okay, what does that mean exactly? So what I thought we would do is just pick one from each section, from each of those, to just think of that we maybe could try and incorporate into our practice tomorrow morning. So behavioral therapy, this is something like journaling, food journaling. We know that if we record in an app or even pen and paper, food intake and activity, it creates a mindful approach. And when we think about what we're eating, then that makes us more likely to actually have healthier eating and healthier behaviors. Cognitive therapy, well, cognitive restructuring is an example of that. And that can be reframing expectations. So the average patient who is wanting to lose weight in Canada, by a survey we did, a study published, 19% weight. Well, that's very difficult to accomplish with lifestyle changes. Even pharmacotherapy, currently, it's tough to get 19% weight loss. And then patients feel like they haven't had success if they lose only 5 or 10%. But we know that improves health. So we want to reframe what their expectations are. And then from a values-based strategy perspective, this is really important. We want to take the numbers, the focus off of the numbers on the scale and put it onto improving health. Ask Randeep, what are your goals in weight management? Well, you know, I feel I can't keep up with my wife when I go for a walk, and I'd like to have more energy to do that. So record that. And at the next appointment, you can bring that up and say, so how's it going with being more active with your wife? Sleep, time, and stress, those are all 1-hour talks each. So we'll pass on those for now. There's lots of stuff on my blog, and we certainly could talk about that in the panel or talk about it another day. And then finally, the 4th and 5th A's of obesity are agreeing on a plan with our patient and assisting them in achieving the goals. So with Randeep, his goal is to be able to walk his golf course. Okay, that's a good one. Great. We want to assess medications. We've identified his sulfonylurea is a culprit here. We want to get rid of that. We'd want to introduce a GLP-1, of course, for cardiovascular benefits, also for weight loss capacity. And then goals we set are food journaling, no phone in the bed at night, because we know that the light and the stimulus actually makes it harder to sleep, and that can contribute to weight struggles. And we want to tailor the nutrition and activity plan with his allied healthcare team. So the key points from that discussion is that we can do it. Look, we did it in 12 minutes. So we can talk about weight management in 12 minutes in a visit. Eat less, move more does not work because we're built to defend our body weight. Medical nutrition therapy, which is a permanent dietary plan, and physical activity should be a part of all weight management plans. And remember that the 3 pillars of obesity treatment support the outcome of a better ability to adhere to the nutrition plan and physical activity. Thanks very much.
Thank you, Sue. Great to hear all that. And I have questions for you again, if you don't have questions from the audience, but I hope they will come in. Please put in your questions in the Q&A, or you can ask them live afterwards, but it's interesting when you can see them before. Sue has prepared a few slides on nutrition.
I just threw together a couple of thoughts here as Dr. Stephen Piper wasn't able to join us. Most of what I'm going to say about the dietary aspects is from the Obesity Canada guidelines. But what I would also say is that the Diabetes Canada guidelines and many guidelines across Europe and Canada, America, you see them here on the left, that we all agree that lifestyle interventions remain a cornerstone of chronic disease prevention. And that, of course, includes the dietary approach. So there is a paradigm shift, which we see both in the Diabetes Canada guidelines and also in the Obesity Canada guidelines, moving away from a prescriptive nutrient-based, you need to have X% carbs, X% fat, X%. We got to get rid of that, because that is not something that patients are likely to follow long-term. And when we are helping them achieve a healthier lifestyle, we need to do this with a permanent lifestyle change, something that they can adhere to, something that fits with their values. So we've moved to a food and dietary pattern-based recommendation strategy rather than a prescriptive nutrient-based strategy. So Diabetes Canada highlights values and preferences are important. Adherence, that's the key, right? If we try to tell everyone that they need to eat the Mediterranean diet because it reduces cardiovascular events, well, the Mediterranean diet is great, but not everyone wants to eat the Mediterranean diet. So we need to find things that a pattern that best fits with the patient's values and preferences, allowing them to achieve the greatest adherence over the long term. So as I mentioned a few minutes ago, in the Obesity Canada guidelines, we talk about dietary approach as medical nutrition therapy, or MNT. And we took out the word diet because diet implies temporary. And also there's a lot of radical diets like the cabbage soup diet or the, all kinds of crazy diets that have no evidence behind them and don't make any sense and can even be dangerous. So again, in our Obesity Canada guidelines, we have the same theme: personalized, safe, effective, nutritionally adequate, culturally acceptable, and affordable, with the goal of long-term adherence. So when we talk about then to get into the details of that, well, we do in the Obesity Canada guidelines suggest that Canada's food guide can be used as a foundation. And then there's a wonderful chapter on medical nutrition therapy in the guidelines, which I encourage you to have a look at. There are many MNT approaches that have evidence for improving health. Now, remember, this is not specific to diabetes. This is the Obesity Canada guidelines. But within that, the same literature review process as we have in the Diabetes Canada guidelines for obesity management, this is a list of some of the examples of diets that have been shown to improve health. Now, not all of these improve weight, but all of them have some health benefit. And many of them can be appropriate for people with diabetes as well, of course. We also talk about the health benefits of particular foods. So we want to still emphasize healthy choices, but we want to move away from being prescriptive on, percentage of protein, carb, fat, and so forth. So that was some of the key points I thought that I could bring together sort of at the last minute there, as Dr. Stephen Piper wasn't able to join us. And from there, I think we've got some great time for some questions.
Excellent. We do have questions already on exercise, and as some come on nutrition and obesity. I'll just ask you a quick one, and both of you can answer, actually. It's about since this is about patients with diabetes and perhaps versus those without diabetes, are there any medical nutrition therapies that you would not recommend for a diabetic patient?
So ketogenic is a very popular diet, and I get asked about that one a lot. And there are certainly some concerns about the ketogenic diet in the context of having type 2 diabetes. And then the other one is intermittent fasting that I can potentially have some concerns about. And it's quite a lengthy discussion, I think, to go into details about both of them. But what we want to think about from the ketogenic perspective is that if you're on a ketogenic diet, you have more ketones, right? That's part of how that's why it's named that way. And there are some patients with diabetes who may have a higher risk of diabetic ketoacidosis, right? So for example, a patient with type 1 diabetes, I consider a keto diet to be contraindicated. I also recommend against a ketogenic diet in a patient with type 2 diabetes who's needing insulin in a 4 times a day or MDI, multiple daily injection format, because that patient probably doesn't have a lot of their own insulin production at that point, since they're needing insulin with meals plus the basal. So they're at a higher risk of DKA. And then the other group, and this is really important for you guys as a cardiology team, SGLT2 inhibitors. Why? Because there is about a 1 in 1,000 risk of getting diabetic ketoacidosis on an SGLT2 inhibitor. So if you throw a ketogenic diet into that mix, then you can have a higher risk. And I've blogged about all that as well if you want some notes to share with patients or to read later as well. And then intermittent fasting, sorry, I'm kind of blabbing on here, but for intermittent fasting, there's many types of intermittent fasting. There's ones where people fast for 24 hours at a time, every second day. There's time restricted feeding. There's 5-2. There's a whole bunch of different ones, which I've blogged on as well. And so really whether those are okay is going to be a very patient specific discussion. What kind of intermittent fasting are they wanting to do? What are they taking for diabetes? If you're on insulin or sulfonylureas or the meglitinides, which is like glucanorm or peglinide, these are the meds that can cause low blood sugar. So you need to be very careful if you're making a change like that and fasting for sometimes yes, sometimes no. How do you deal with those medications? How do you deal with the insulin? And then from the SGLT2 perspective, I'm nervous if they're doing a fasting where they're like fasting for a whole day, because again, if you're fasting too long, then you start to generate ketones and maybe there's a higher risk of ketoacidosis. So that would be a concern, as well as hydration.
Excellent, all good advice. I'm hoping that we can find these things on the blog, and I'm hoping Philip will have a blog soon. And we have a few things for you, Philip, that came in the chat box. So the first one is in the MHI Diabetes Prevention Clinic, what was meant by moderate CHO restriction? Is that the percentage of total calories or how many grams per day were CHO?
Yeah, so we, of course, as Sue mentioned, we go very much on a personalized approach to both physical activity and diet. And of course, when we look at restriction of carbohydrates, we try to limit the percentage of calories that are typically prescribed for patients that come from carbohydrates. The percentage per se will be, of course, different depending on the baseline of what patients do. But we typically go progressively lower and reach a fairly small amount or as minimal as the patients will tolerate as far as the refined carbohydrates, especially. Of course, for something like if we look at different at a general number, it'd be definitely less than 40%.
Excellent. And the second one is how much, and possibly both of you could answer, but Philip is our exercise specialist. So how much does HbA1c drop? How much more mortality reduction is achieved with exercise as well? So these are two questions in one from Dr. Jim.
So with regards to how much mortality is lowered, because of course most studies will actually combine physical activity and diet. So of course it's sometimes difficult to identify and isolate the contribution of both contributors. But if you look at physical activity per se, it's typically in the realm of 0.8% or 1%. And of course, this is achieved to, again, significant amount. The mortality associated with this, or the reduction in mortality, is proportional. And of course, is about something like 1% about reduction in absolute mortality.
Excellent. And I believe the one from Colin Rose is for so in people with large waist circumferences and obvious self-destructive lifestyle, is it ethical to start drugs for high glucose, high blood pressure, high cholesterol before they have made documented changes in those lifestyles, considering that curing the blood numbers with drugs will remove incentive to change the habits?
That's a great question. So the way that I would encourage us to look at it is that actually using medication to help to treat these issues, first of all, we don't want to delay treatment, right? So when a patient is struggling with weight and having, you know, as you described, self-destructive behaviors, well, why are they having those behaviors? You know, maybe it's a patient who was sexually abused in a childhood and they bury themselves inside of a larger body because they're afraid of sexual attention if they lose weight. That's not actually self-destructive. That's someone trying to protect themselves. And if no one has ever talked about that, if no one has ever addressed that or opened a conversation, well, how's that patient ever going to have success with lifestyle treatment? So we don't want to delay treating the health-related complications of weight just because we don't see the patient making changes. What I would recommend we do is use the treatments because we need to treat these health issues. We know that the longer we let blood pressure run high, the longer A1C is running high, we have complications developing, right? So we don't want to punish that patient that they're not having success with lifestyle change by withholding the treatments. We want to get them treated. And at the same time, we really need to explore and open the door to having a conversation about what the issues are that are contributing to that person's weight struggle and challenges in making the lifestyle changes. And then the third point I would say is that we now are so fortunate to have medications that actually can make it easier for patients to make changes. And the great examples here are the medications that reduce hunger, induce satiety, and that's the GLP-1 receptor agonists. So I have had so many patients come back to say, Dr. Sue, you changed my life with starting this medication. Speaking of GLP-1s, I don't feel so hungry anymore. I'm not so obsessed with food. I don't have the same cravings. I don't get the same satisfaction out of eating fast food. One person said, I can't stop thinking about baby carrots. I used to think about pizza all the time. Now I think about baby carrots. It's really quite empowering. And with the newer medications that we're developing as well, we're now getting more, not just an effect of these medications on the homeostatic mechanisms, meaning hunger and fullness, but also on the hedonic mechanisms. And that's that wanting, liking, cravings, and so forth. And it gives patients that many times that freedom to be able to have more control and to manage those lifestyle concerns. SGLT2s, of course, also cause weight loss, but they don't reduce hunger or cravings. They don't act in the brain that way, of course, but they are also wonderful for the weight struggle, but they don't give the patient, they don't have an effect in the brain that way.
Excellent. Good question, good answer. I don't see any more questions coming. Anybody can send them or just raise their hands. I have one for you, Philip. I thought also about the more elderly. I know your study had about an average age of 67 years old. Would you have specific types of exercises for elderly with diabetes or elderly with cardiovascular disease at large?
No, we typically would include, again, the three different types, which they would be aerobic, resistance, and stability and balance. We, of course, as I mentioned before, would maybe include a little bit more balance exercises and stretching for older patients if they are, let's say, extremely sedentary in the first place. But we would definitely include the three types.
Excellent. And I had a question about the microbiome study. Did they actually test various diets or should I say medical nutrition therapy? Sorry, MNTs, I'll learn that.
They're talking about the one I mentioned was actually physical activity. So they maintained the diet the same, and they of course studied the microbiome depending on the physical exertion patterns and the physical activity of the patient. So response to physical activity.
Okay, so there is. Are you aware, Sue, of the if the modification of the microbiome is achieved by certain specific diets, and if that can change something to cardiovascular disease, or are we going too far with research studies here?
I don't have that answer at the tip of my tongue, but certainly there's a lot of great data and great literature being done looking at the microbiome and the association of different microbiome profiles with diabetes, metabolic syndrome, obesity, and so forth, and different dietary interventions. I don't know that there's anything ground earth shaking on that, but there is a lot of great studies looking at probiotics, prebiotics, even fecal transplants, to try to improve the metabolic profile with some good animal data. I think we're still quite a ways from those kinds of interventions in humans that are proven to be effective, but I think there's a lot of potential there.
Excellent. And we have one more question from Dr. Jin. It says, our cardiac rehab doctors say that the programs are not focused on weight loss. Any programs that actually help with weight loss?
So from a commercial program perspective, the only commercial program that I suggest to patients is Weight Watchers, because it's about mindfulness, right? So you have to count your points. So you engages in mindful eating, mindful activity, mindful habits. And it's something that a person can stick to for the long term, because it's not prescriptive. It's not saying you must eat this, 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 and you can't have this, this, this. This is for weight management in general. Jenny Craig is the other one that has good data behind it. But the problem is you can't order Jenny Craig to your house for the rest of your life. And a lot of it's very high salt, which can be problematic with hypertension and CVD and so forth. Provincially, there's different centers will have different programs that are evidence-based and very helpful for patients. In Alberta, we have something called Building Healthy Lifestyles. There's going to be different things that each province has. So I would suggest just primary care usually has their finger on the pulse of what is available in each locale.
Excellent. Philip, do you have anything to add to that in terms of the exercise programs don't make you lose weight?
No, see, of course, it needs to be the weight part of prevention and treating diabetes, preventing and targeting remission is really the nutrition part. The exercise part, of course, is there to help. It's there to provide ample different benefits that are somewhat independent of the amount of weight loss. And therefore, that's what I said, that really the benefits of physical activity cannot be limited to only measuring how much weight patients lose when they exercise versus when they don't. And of course, it needs to be combined. And this is why we are going forward with our clinic, and we are tweaking and adapting after what we call the so-called pilot project, which I just mentioned some of the results. We, of course, are going forward with 2 new trials and protocols that will be studied, formally studied, called Diabetic 1 and 2, and they will go much deeper into the different interventions. It will include it will be for motivated patients and for patients who will want to really change their lifestyle. We, of course, go the direction of in the philosophy that we can go further, typically. And we will go towards time-restricted feeding and even fasting in some of those patients. And we'll try to go further into the behavioral changes and behavioral approaches to changing lifestyle, in addition to physical activity and including longer-term interventions, because we have seen somewhat of a plateau after 3 months. We would like to try to go further in improving further on the benefits of exercise if we go for 12 months. Similarly with diet, we would like to have some perspective on how the patient is evolving throughout the program, whether they need an intervention changed at 3 months because they have had some improvements, but not necessarily maximum benefits. We would like to offer them alternatives, and sometimes go from a carbohydrate restricted Mediterranean to maybe add let's say some fasting and add some time restricted feeding, and eventually go towards something much more ketogenic type, diet, but we have a big restriction on what we call the ketogenic diet, where we absolutely do not lack the type of fats that are typically promoted in this type of diet. We would like the ketogenic diet using good fats, and therefore this is much more limiting. And but it is at the end of the spectrum in our strategies, nutritional strategies. So we go from carbohydrate restriction in surrounding the Mediterranean diet to time-restricted feeding to intermittent fasting to Cornish type diets and approaches to ketogenic good fat approaches. So. And again, it needs to be adapted to the patient, whatever they like and whatever they prefer.
Excellent. Well, I'm thinking we should all go to your to your clinics. Maybe I was thinking also a psychologist, or because there are a lot of psychological issues in there as well, and we all know that. But it's hard to see how to approach them. There are some meds also that make you increase the weight and how to increase the will to exercise would be other interesting stuff, but we can't discuss about everything, but it looks like we're going to have some more of those talks. And I would like to thank both of you for being there tonight. And I would like to thank also the attendees and thank you for your participation and attention. I hope you'll join us for other Q+ programs. And I thank our presenters again for taking so much time and answering all our questions as we go. Thank you so much. And thank you, Sophia, Geneviève, the interpret, also for participating behind the scenes, helping us with everything. Thank you.
And thank you, Eileen, for being a wonderful chair.
Thanks.
Thank you.
Have a good evening.
Thank you, everybody.